Good afternoon. Do we have all the presenters here? Can I have the show of hands, please? Who are the presenters? 1, 2, 3, 4, 5, 6, 7, 8. Okay, 2. Thank you. So there are almost 14 talks to be finished in 75 minutes. So I request all the presenters to keep up to the time. The allotted time for your presentation is 5 minutes. It's not 5 plus 1, it is 5 minutes. So once the 5 minutes is over, we are forced to request you to conclude. So please don't extend your talk. You'll be eating up into the next session. So responsibility is on us to hand over the session, the dais to the next session. So please stick to your time. Ravi, shall we start? Are the other chairpersons and convener, they are coming or no? Dr. Krishna Teja and Dr. Lakshmaya. Is Dr. Krishna Teja and Dr. Lakshmaya, did they respond? Are they coming? The other two? Dr. Lakshmaya and Dr. Krishna Teja. Could you speak to them? Okay. They're not lifting. We can start, I guess. So can I have the first presenter, please? Dr. Vishal Prakash Nandeshwar. He'll be presenting on study of association between axial length and retinal vein occlusion.
Good afternoon, everyone. Myself, Dr. Vishal Prakash Nandeshwar, presenting my paper, Study of Association between Axial Length and Retinal Vein Occlusion. Introduction. Retinal vein occlusion is the most common form of retinal vascular disease following diabetic retinopathy and may result in permanent vision loss. It occurs as a result of obstruction of blood circulation of retinal vein due to an adjacent blood vessel, which results in stoppage of blood flow causing retinal hemorrhages. Depending on the site of involvement, venous occlusions in retina are classified into central retinal vein occlusion, branch retinal vein occlusion, and hemicentral retinal vein occlusion. It is mostly a disease of an older population. Many systemic and local factors can predispose to the development of RVO, including hypertension, diabetes mellitus, hyperviscosity, hyperlipidemia, primary open-angle glaucoma. Since the incidence of disease is rising day by day, newer predisposing factors like shorter axial length, hyperlipidemia, systemic inflammatory diseases involving eye smoking, hyperhomocystinemia are being discovered. Aim and objectives of my study was this study has been undertaken to evaluate the correlation between axial length and retinal vein occlusion. Materials and methods. This observational hospital-based study was performed in ophthalmology department of IGH, Rourkela between November 2022 to June 2023. After taking proper approval from the Institutional Ethics Committee, all the patients attending the OPD of IGH Rourkela with a history of diminution of vision were thoroughly evaluated. Patients diagnosed with retinal vein occlusions were included in the study. Inclusion criteria: all patients diagnosed with retinal vein occlusion, a patient who gave their consents for the study. Exclusion criteria: previous intraocular surgery, eye trauma, other retinal or neurological diseases like multiple sclerosis, intraocular inflammation or tumor, significant ocular media opacities like dense cataracts. Material and methods: 48 patients with unilateral retinal vein occlusion, 35 patients of BRVO, 13 patients with CRVO, of mean age 60 plus minus 13 years, range that is 47 to 73 years, were enrolled in the study group. The control group consists of 50 eyes of 50 randomly selected age matches volunteers, mean age 60 plus minus 13 years, range 47 to 73 years. Detailed ophthalmological examination, visual acuity, refraction, slit lamp, biomicroscopy, gonioscopy, intraocular pressure measurement with uplumination tonometry, indirect ophthalmoscopy following pupil dilation and fundus fluorescence angiography was done in all RVO patients. Axial length of all 48 RVO patients and 50 controls were measured by A-scan ultrasonography. All RVO patients underwent detailed systemic, cardiological, and hematological examinations and investigations including blood sugar, blood pressure measurement, lipid profile, complete hemogram to find out the other risk factors for development of RVO. Data was analyzed by using SPSS software. All differences associated with chance probability of less than and equal to 0.05 was considered statistically significant. Results of my study was total 48 patients, 35 patients of BRVO and 13 patients of CRVO, and 50 controls of age group 47 to 73 years were included in the study. The mean axial length of BRVO patient was 21.76 plus minus 0.07 millimeters. Mean axial length of CRVO patients was 21.23 plus minus 0.04 of millimeter. Mean axial length of control group was 23.53 plus minus 0.06 millimeter. The axial length of eyes of patients of RVO, retinal vein occlusion, BRVO and CRVO were shorter than axial length of eyes of control group, the differences of which was statistically significant. This is here we can see the association of other risk factors like hypertension, diabetes, dyslipidemia, glaucoma and RVO in BRVO and CRVO patients. This is the comparison of axial length patients of RVO, CRVO and BRVO and control group. Here we can see that the shorter axial length corresponds to the CRVO and BRVO patients and higher axial length corresponds to the control group. Discussion. The study showed that axial length of eyes of patients with retinal vein occlusion, BRVO and CRVO was significantly less as compared to those of control groups. Proportion of well-known risk factors, hypertension, diabetes mellitus, dyslipidemia, glaucoma in the RVO patients were consistent with the previous studies. Our findings on axial length of RVO patients were consistent with the studies published by Antija CJT et al., which shows that shorter axial length and vitreous chamber depth might be a potential anatomical predisposing factor for development either of CRVO or BRVO. Another study published by Arithrak et al. Also showed that axial lengths in CRVO and BRVO are significantly shorter than in controls, which may be a risk factor in the development of CRVO and BRVO. However, our findings were in contrast to studies published by Simmons B et al., Bandello F et al. And Mogini et al., which showed that hyperopia as measured by axial length is not a risk factor for retinal vein occlusion. Study published by
Can you conclude, please? 5 minutes is okay.
Our study, this study shows that there is a significant correlation between shorter axial length and retinal vein occlusion. Thus, it can be postulated that shorter axial length can be an important predisposing factor for development of retinal vein occlusion.
Yeah, before we go to the discussion, can I have the next presenter, please? Dr. Sanjeev Kumar Gupta. Sorry, Dr. Tapan Ramawat. Is Dr. Tapan here? He's not there. Can we have Dr. Sharath Hegde? He's not there. Dr. Pavitra Panirselvam? She's also not there. Dr. Manisha Kumari? Onto the desk.
Yeah, do you think this is a conclusion?
So we have taken only 50 controls and 50.
Yeah, in other words, see, there are a lot of confounding factors here. Okay, there is a hypertension, there is a diabetes. The ideal way of doing this study with a shorter sample size would have been non-hypertensive, non-diabetic patients ending up in vein occlusions.
Yes.
In that, probably we have ruled out other, and you could have proven this.
Yes.
Considering that these can be the factors which can contribute to the vein occlusion,
Yes.
and axial length plays another role in it, then you need a larger sample size.
Yes.
Okay, good study anyways.
Thank you.
Yeah. Adherence of intravitreal anti-VEGF therapy and obstacle to the cure. Over to you.
Good afternoon, everyone. I am going to present on reason for non-adherence to intravitreal anti-VEGF therapy. No financial disclosure and patient consent have been obtained. Introduction. Oculovascular diseases are among the leading causes of visual impairment and blindness worldwide. Diabetic retinopathy, diabetic macular edema, age-related macular degeneration, and retinal vein occlusion are the most prevalent oculovascular disorders. Anti-VEGFs have an important role in treating common vision-threatening retinal diseases, and multiple studies have demonstrated the efficacy of intravitreal anti-VEGF injection for the management of these diseases. On the other hand, anti-VEGF injections need to be repeated due to their short-term efficacy. Aim to determine reasons for non-compliance to intravitreal anti-VEGF therapy among patients of a tertiary care center. Material and methods. A retrospective study was done on patients attending a tertiary care center who were initiated on intravitreal anti-VEGF therapy between May and October 2022. Data regarding the type of injection, number of injections, its indication, scheduled follow-up, missed visits, and reason for discontinuation of treatment was obtained from hospital records. Result: 76 patients were recruited in the study, 29 males, 47 females, mean age 51 year, 31% had CRVO, 53% diabetic macular edema, 16% had ARMD, and a large number of patients, 44, that is 58%, had lost to follow-up. This is pie chart showing reason for non-compliance, the most common reason being non-affordability, 43%, followed by dissatisfaction, which constituted 20% reason, followed by travel difficulty, which constituted 16%, comorbidity and negligence 7%, fear 5%, and discomfort 2%. This is the bar chart showing the number of patients who have left treatment because of various reasons, the most common being non-affordability. Conclusion: the most prominent reason for refusing further treatment was non-affordability, 43%, n is equal to 19, followed by dissatisfaction, 20%, n is equal to 9. Other reasons were travel inconvenience, comorbidity, negligence, fear, and discomfort. A significant number of patients, that is 58%, had left treatment in between. So the factors involved in non-compliance need to be addressed for better treatment outcome. These are references. Thank you.
Before we go for the discussion, can we have Dr. Smriti Chaudhary? Is she here? Yeah. Dr. Manisha, it's a very nice study. In fact, this is the need of the hour. It is well thought out study. Only thing is, if it were not to be a retrospective, it were to be a prospective. Because what happens in the retrospective, you don't tend to document the exact cause for discontinuation. Lot of details are, and in this kind of study, the devil lies in the details. So you need to be specifically noting down after like how many doses the patient missed it, and what was the type of anti-VEGF, and who had counseled them. Is it the doctor or the counselor? Because these are the studies which can actually bring out a lot of light on the practice space. Like you can give a lot of guidelines. Like, okay, these many patients were counseled by the counselors, so they were dropped out. So the counseling should be taken up by the doctors and not the counselors. Or the traveling. If traveling is an issue, then it needs an extra counseling. So if it were to be a prospective study, it could have been a much better study.
Thank you, sir.
Yeah, non-affordability, as you mentioned, is clearly a biggest factor. But coming to dissatisfaction, that might be resulting from the lack of proper counseling and unrealistic expectations from patients.
Yes.
So as are told, it needs to be like to give a better outcome. It has to be a prospective study and all those variables have to be mentioned.
So as you already have an idea of this study, maybe you can now to do a proper protocol, get your IRB, the ethics committee approval, because many of these studies, if you want to publish or present, you need those ethics committee approval things. Okay?
Thank you, sir.
Dr. Smriti Chaudhary will be presenting on eyes Odyssey, retinal vasculitis in a patient with autoimmune hepatitis and MCTD. Over to you.
Good afternoon, everyone. I am Dr. Smriti Chaudhary, second year ophthalmology resident, and today I will be taking you through the eyes Odyssey. So there are no financial interest or conflicts of interest in the subject matter, and all appropriate informed consents were obtained from the patient. So autoimmune liver disease is a chronic disease which affects eyes as a part of the autoimmune process. Corrective conjunctivitis sicca is the most common ocular manifestation, whereas cataract is the most common complication of autoimmune liver disease due to the corticosteroid treatment. So retina is involved as a part of posterior uveitis, which manifests as retinal whitening, vasculitis, hemorrhages, macular edema, and chorioretinal lesions. The correlations between AIH and uveitis with the other systemic diseases has been well established, but not those between them. So there have been only 11 cases documented globally that point to autoimmune hepatitis as a cause of uveitis. So an ophthalmologist's role is emphasized by the possibility that ocular involvement may be correlated with the systemic disease activity and progression and may occur before the systemic symptoms. So here we present to you a rare case of retinal vasculitis and branch retinal artery occlusion in a patient of autoimmune hepatitis and mixed connective tissue disease. So a 39-year-old female patient presented to IOPD with chief complaints of blurring of vision and flashes in left eye since 3 months. It was sudden in onset, painless and progressive, and she also complained of straight lines appearing wavy. So she was a known case of decompensated liver cirrhosis and autoimmune hepatitis with portal hypertension and hypothyroidism. On further workup, she was also found to have mixed connective tissue disorder due to anti-RNP and anti-double stranded DNA positivity. So our ocular examination showed best corrective visual acuity in right eye as 6.6 N6, while in left eye it was 6/60 and N36. So the anterior segment examination right eye was within normal limits, while the fundus examination showed venous sheathing and few hemorrhages in the temporal periphery. The disc and macula were normal in the right eye. So here is the fundus photo. I apologize for the bad quality of the fundus photo. So the anterior segment examination of left eye showed grade 1 RAPD and rest was normal, while the dilated fundus examination showed a pale disc, the foveal reflex was absent, and there was arteriolar narrowing and sheathing of inferotemporal branch of retinal artery. So here's a fundus photo of left eye. So Amsler's test and color vision test were abnormal in the left eye. The Schirmer test revealed bilateral severe dry eyes. So Humphrey field analysis was not reliable in this patient, but OCT macula showed foveal thinning, as you can see here, and there's also widened foveal contour in the left eye. So So here's a picture of OCT angiography of the patient showing areas of capillary dropouts due to the vasculitis. So she was diagnosed with right eye vasculitis and left eye old branch retinal artery occlusion. So although it affects people of all ages, autoimmune hepatitis has been found to be more common in women than men. Rheumatoid arthritis, ulcerative colitis, and thyroiditis are the few examples which are often linked to AIH. So uveitis, however, has not been established much as an extrahepatic manifestation of AIH. So bilateral chronic persistent pan-uveitis is the typical first sign which needs an aggressive treatment. So retinal vasculitis involving the inflammation of vessels is a sight-threatening condition. So cotton wool spots, perivascular sheathing with inflammatory exudates, and retinal hemorrhages and occlusion are the hallmarks of retinal vasculitis. It is a clinical diagnosis that we confirm with OCT and FFA. So to find the etiology, we need a multidisciplinary approach along with lab investigations. So majority of AIH patients need a long maintenance therapy, and milder disease is found to have better response to treatment. Corticosteroids with immunosuppressants are the treatment of choice, followed by low-dose steroid therapy to avoid any remissions. Here our patient was started on systemic steroids and immunosuppressants after rheumatology clearance, and she was also started on antiplatelets later due to anti-beta-2 glycoprotein and anti-dsDNA positivity. So she was also prescribed artificial tears 4 times a day. She has been on regular follow with gastroenterology and ophthalmology departments. So the moral of the story is that uveitis should be ruled out in all cases of proven autoimmune hepatitis, and autoimmune hepatitis should be included in the differential diagnosis of all cases presenting with uveitis-like features. So I would like to thank Dr. Shailaja, my associate professor, and Dr. Yogesh Kamath, unit chief and head of department of the ophthalmology at Kasturba Medical College, Manipal, for their valuable support and guidance and granting me the permission to present this paper. I would like to thank All India Ophthalmology Society for giving me the platform to present this paper. So these are my references. Thank you.
Do we have Dr. Shreyas TS here? So nice presentation, good documentation.
Thank you, sir.
Only thing is there is a bit of generalization which I have done. That is branch retinal arterial occlusion, just going by the sheathing which has happened. That kind of sheathing on the OCT picture can be because of the perivascular exudates and vasculitis which takes place and then heals. And also the macula OCT picture, what you are showing, you can see it following any retinochoroiditis or subsequent to the resolution of inflammatory macular edema. So you can for sure put it as a branch retinal artery occlusion only if you have documented in acute stage.
Okay, sir.
Okay, and yes, the point usually case reports stand last in the evidence, but because this is a unique case where one has ophthalmologist has to be aware of the autoimmune hepatitis patients needs to be, the eye evaluation is important. So this is a message has to be driven to the rheumatologist and
Yes,
the team who deal with the vasculitis.
Yes.
In the nice presentation.
Thank you, sir.
Dr. Shreyas will be presenting on multimodal imaging characteristics and treatment outcome of retinal capillary microorganisms. Over to you, Dr. Shreyas.
Good afternoon, everyone. I'll be presenting a study on multimodal imaging characteristics and treatment outcomes of retinal capillary macroaneurysms. So, as we all know, microaneurysms have a size of less than 125 microns. They have a capillary origin. They occur usually in clusters and are associated with retinal vascular diseases like diabetic retinopathy and vascular occlusions. In the same lines, retinal capillary macroaneurysms, also known as RCMs, have a size of more than 125 microns. They also have capillary origin. They are usually solitary, and they may or may not be associated with retinal vascular diseases. So based on this background, we have the objective of this study is to assess the imaging characteristics and treatment outcomes of RCMs. It was a retrospective case series. So even though we routinely screen our patients for diabetes, and we usually see for these aneurysms in chronic conditions, we included patients in whom a diagnosis of RCM was made only after careful examination aided by OCT and fundus fluorescein angiography. Exclusion criteria included conditions which are known to be associated with larger aneurysms. So by definition, RCMs were defined as orange-red retinal lesions with the oval structure on OCT with size greater than 125 microns with no direct communication to retinal arteries or veins. So we collected the clinical profile of our patients. Fundus photo was documented. Fundus fluorescein angiography was done to know their angiographic characteristics and associated retinal vascular pathologies. OCT macular cube and OCT 20-line raster was done to know the characteristic features of the RCM lesions, and response to various treatments were noted. Coming on to the results, even though we routinely screened our patients, we could only identify 7 patients which had typical RCMs. So we included 8 eyes of 7 patients. 6 were males and 1 was female. Mean age was 62 years. Best corrected visual acuity was in the range of 6/6 to 6/60 depending on the involvement of macula. 6 patients had diabetes, 2 patients had hypertension, and 1 patient had CKD. So these were the fundus characteristics of the patients. So to summarize, lesions were solitary in 75% of the patients and multiple in 2 of them. Most of the lesions were located in the posterior pole. It was exudative in almost 75% of the patients. They had an orange-red lesion in all of the patients and associated with retinal hemorrhages in 5 of the patients, visible retinal thickening in 3 of them, and associated exudate rings or clusters in 6 of the patients. So associated retinal vascular pathologies, almost 75% of the patients had diabetic retinopathy association. 1 patient did not have any retinal vascular disease, and 1 patient had BRVO. So these were some of the fundus pictures of our patients. 1 patient had a perifoveal RCM. The other patient had a RCM along the papillomacular bundle. So the last pictures you can see multiple RCM lesions. So coming on to the OCT characteristics, all the lesions had a oval structure. Average size of the RCMs was around 314 microns. They extended from RNFL to outer layers. They had a hyperreflective wall with non-homogeneous variably reflective contents, as you can see in the picture. Surrounding retina showed presence of cysts, schisis, NSDs, hyperreflective dots, and hard X-rays. RCM as a cause of macular edema in our patients was attributable in 3 out of the 8 eyes. So these are some of the OCT pictures of the RCM lesions. So coming on to the fundus fluorescein angiography characteristics. So we had hyperfluorescent lesions with minimal leak in almost 75% of the patients. 1 patient, as you can see in the second picture, had a hypofluorescent lesion with no leak. So hyperfluorescent lesion with no leak was seen in 1 patient. So this patient had a hyperfluorescent lesion with no leak. So coming on to the treatment, in one of the patients we gave anti-VEGF which showed very poor response and hence focal laser was considered. In another patient, direct focal laser was considered. In third patient, we gave IVTA. It showed only decrease in macular edema but no change in size of the lesion, where again we opted for focal laser and there was complete regression. In many of our patients, observation was also a treatment strategy. Slide is not moving. हैंग हो गया.
So what's your take-home message with your presentation?
So just one slide is there. In that time, want to conclude that.
Yeah, that's what. Without slide, we can go ahead. Otherwise,
Okay.
if it comes, we'll give you time. But meanwhile, we can have.
Sir, based on our experience and based on the literature, what we found that even though intravitreal therapy can be considered, so most of these lesions very well respond to focal therapy. So intravitreal injections can be considered for lesions which are very close to fovea and where you feel there is a risk of damage to the fovea. In these cases, we might consider multiple injections. Usually they don't respond to a single injections, but we do not have any information on giving multiple injections, but they respond very well to focal laser. Again, after this slide, it's not moving. That's okay. Some problem.
Here's a nice collection of cases, and the literature does suggest like what you have put across. Only thing is, yeah, the indication for anti-VEGF will be the macular edema. Presence of macular edema. That too, we do wait for some time, for say 2 to 4 weeks, and if then it doesn't resolve.
But most studies say that anti-VEGF, it doesn't usually work that well.
Yeah, so in those cases, you can top it up with a focal laser.
Focal laser.
Otherwise, many times, so observation is one. If it's not involved in the
If
macula.
the macular edema is stable and vision is good, observation is also a good option.
Yeah, so yeah, point well taken. Right. Can we have the next presenter,
Thank you,
please? Dr. Here? Yeah, please. You can come and sit here.
Good afternoon, everyone. Today, I'm going to present a paper on role of B-scan ultrasonography to evaluate posterior segment pathology in patients with opaque media. Conflicts of interest are nil and no financial interest. Introduction: ultrasonography is one of the most useful non-invasive techniques for evaluation of posterior segment of the eye. Baum and Greenwood developed the first brightness mode scan in ophthalmology. Introduction of first commercially available B-scan was by Coleman and Associates in early 1970s. Thereafter, Bronson introduced a portable contact B-scan machine for ophthalmic use. Aim: to evaluate posterior segment pathology using B-scan ultrasonogram in patients with opaque media posted for cataract surgery. Materials and methods: a prospective study was carried out from October 2022 to Jan 2023. 100 patients with dense cataract posted for cataract surgery were included in the study based on the predefined inclusion and exclusion criteria. A proper informed consent was obtained and ophthalmic examination was carried out. Inclusion criteria was age more than 40 years, both the genders, and no other media opacities due to anterior segment pathologies. Fundus cannot be viewed by ophthalmoscopy. My exclusion criteria were aged less than 40 years, any media opacities due to anterior segment pathology, and if fundus can be viewed by ophthalmoscopy. Patient evaluation: detailed history was taken and examination was done in all the 100 patients with dense cataract posted for cataract surgery. Visual acuity, slit lamp examination, and intraocular pressure were recorded. Procedure was explained to the patient for their cooperation. B-scan ultrasonography was done in all the 100 cases with a probe using direct contact method with the patient in supine position. After applying gel over the probe, it was placed over the globe of closed eye. Axial, longitudinal, and transverse views of B-scan were taken. High gain and low gain sensitivity was selected during the procedure and images documented. Observations and results. Age: in this study, most of the patients of 45% were in the age group of 61 to 70 years. and most of the patient was females, contributing to 55%. Laterality, most of the patients had dense cataract in right eye, 52%, and vision, most of them presented with a vision of hand movements followed by perception of light, then counting fingers close to face, counting fingers 1 meter, and the least was counting finger 2 meters. Pupillary assessment, 92 patients had normal pupil, while 3 had RAPD, 3 had sluggish reacting pupil, and 2 with synechiae. And in this study, most of the patients had mature cataract, about 60%. IOP, most of the patients had an IOP of 32 patients, and the least was 1 patient with 22 millimeters of mercury. B-scan findings, 58 patients had normal B-scan, followed by 16 patients with vitreous degenerations and 14 with PVD, 4 with retinal detachment and asteroid hyalosis, 3 with PVD with vitreous degenerations, and 1 was with vitreous hemorrhage. And this is a picture showing nuclear sclerosis grade 4, mature cataract, hypomature Morgagnian, complicated cataracts. And this is the pictures of B-scan showing normal and then vitreous degenerations, PVD, asteroid hyalosis, tractional retinal detachment, PVD with vitreous degenerations, and vitreous hemorrhage. Discussion. In this study of 100 patients, highest were in the age group of 61 to 70 years and the least in the age group of 41 to 50 years. Most of them were females, and 52% had dense cataract in right eye, 40% in left eye, and 8 had in both eyes. Highest percentage had vision of hand movements and the least had counting fingers at 2 meters. Highest had the mature cataract and least was a traumatic cataract. 58% has normal B-scan findings, followed by 16% with vitreous degenerations. 14% has had PVD in my study, which is compared to a study by Qureshi in which 3% had PVD. And 4% had retinal detachment in my study compared to a study by Blumenthal which had 4.5% retinal detachment, and 4% had asteroid hyalosis, which is compared to a study by Qureshi which had 2% had asteroid hyalosis, and 3% had PVD with vitreous degenerations, and 1% had vitreous hemorrhage compared to a study by Salmani where 1.7% had vitreous hemorrhage. Conclusion. Ocular B-scan is a safe, non-invasive technique, and in patients with dense cataracts, posterior segment can be visualized by ophthalmoscopy, and there is also a risk of poor visual prognosis in patients with cataract who may also have coexisting posterior segment abnormalities. In these situations, B-scan ultrasonography is a great method of assessing posterior segment of the eye. These are my references. Thank you.
So you are a postgraduate?
Yes, sir.
Which year?
Second year.
Second year, okay. Nice presentation, nice collection of data. But what was the need for the study?
So,
See, when you come up with a thesis topic, you have to write the gap in the knowledge. You have to do a literature search, and there will be a gap in the knowledge. And then you form a research question, form an hypothesis, then you come across your thesis topic, right? So what do you think was a gap in the literature? So why was this study needed?
To explain the need of B-scan ultrasonography with dense cataracts going off for a cataract surgery.
Is it not, is there enough literature available in this regard?
Yes, sir.
Or is it not a practice that whenever there is a media opacity, you do B-scan? It's there, right? So whenever you choose a research topic, it should be something, I agree, as a postgraduate, your intention is to first get done with your thesis and not fall short of the number of cases which are needed. I totally agree with that. I have gone through that. But then you should make an attempt to make some, go a little step ahead and then do a little with the available infrastructure.
Yes,
okay, thanks.
Thank you, sir.
Dr. Pravalika. Dr. Pravalika will be presenting as combined retinal vascular occlusion, a rare case presentation. Over to you.
Good afternoon, everyone. I am Dr. Pravalika. I am going to present a case of optic nerve granuloma presenting as combined retinal vascular occlusion in miliary tuberculosis, a very rare entity. There is no any financial disclosure. Tuberculosis can have a variety of ocular manifestations which include from anterior to posterior segment of the eye. Visual compromise can also occur with CNS involvement and ATT toxicity, and tuberculomas of the optic nerve per se are rare, and combined retinal vascular occlusion is also rarely reported.
Coming to my case details, a 34-year-old male presented with sudden painless diminution of vision in the right eye 10 days back with history of multiple febrile episodes in the evening associated with chills and dry cough for 1 month. And patient had history of alcoholism and smoking for 15 years. On an examination, patient was thin-built and was febrile, and systemic examination was within normal limit. And ocular examination of the right eye, visual acuity was no perception of right, and other color vision couldn't be assessed, and other anterior segment was normal except for there is central mid-dilated pupil with grade 3 RAPD. And ocular examination of the left eye, vision was 612 with no improvement on pinhole, and color vision was 1/38 plates, and rest was within normal limit with sluggishly reacting pupil. Fundus photography of the right, on fundus examination of the right eye, there is disc edema noted, and arteriolar attenuation was seen with venous segmentation, and there was cherry red spot in the macula with pale retinal background. Fundus examination of left eye was normal except for there is a temporal pallor was noted. With this, we came to a provisional diagnosis of right eye optic neuropathy with central retinal artery occlusion and left eye partial optic atrophy, and these following investigations were done. On optical coherence tomography of right eye, there is a lobulated mask at the optic disc with elevation and hyperreflectivity of the retinal layers and serous detachment. On fundus fluorescent angiography of the right eye, there is increased arm to retina time of both artery and vein, and hyperfluorescence of the optic disc and peripapillary area with capillary non-perfusion of rest of the retina, which is suggestive of combined vascular occlusion. FFE of left eye showed normal dye transit, and B scan of right eye showed raised optic disc. On blood investigation, patient had elevated ESR with microcytic hypochromic anemia, and CRP is elevated, viral markers were negative, sputum for AFB was negative, Mantoux test was negative, but CB-NAT was positive with no resistance to any anti-tubercular medication. Chest X-ray was suggestive of miliary tuberculosis. On contrast enhanced MRI of brain on orbit, there is an ill-defined heterogeneous enhanced lesion at the optic nerve head. Of the left eye also, there is a well-defined lesion at the apex of orbit. And on CE-MRI brain, there are multiple ring-enhancing lesions of various sizes suggestive of tuberculoma after clinical correlation. With this, we came to a final diagnosis of right eye combined retinal vascular occlusion with optic nerve head tuberculoma, left eye partial optic atrophy secondary to tubercular optic neuropathy with disseminated tuberculosis. And patient is started on anti-tubercular treatment with oral prednisolone after pulmonologist consultation and was advised for a monthly follow-up. Coming to the discussion, optic nerve involvement in TB is rare and can occur anywhere along the pathway, and from hematogenous spread to the direct spread from the choroid, and it can present as various clinical presentation ranging from papillitis to optic chiasmatic arachnoiditis, and it is difficult to differentiate it from infectious or non-infectious conditions, and it is also associated with vascular occlusion is very rare. So it should always be considered in this patients living in the endemic areas. Basically, the confirmative investigations are sparse, so corroborative tests can be useful in these patients, and treatment includes anti-tubercular therapy, systemic steroids, despite guarded visual prognosis. And in case of immunocompromised host, the following differential diagnosis can be excluded. What is unique in this patient is presented with only visual symptoms, and the presentation was rare, infiltrative optic neuropathy, and this highlights the role of ocular imaging in the diagnosis of vascular occlusion and neuroimaging in the optic nerve and CNS involvement. And this obviates the need for an invasive procedure like an optic nerve biopsy. And positive CB-NAT in this case helpful in the diagnosis of TB. Coming to the take-home message of my topic, early diagnosis of tubercular optic neuropathy is challenging, and sequential evaluation of optic nerve and other organs by imaging aids in the diagnosis, and potential morbidities of an optic nerve exploration for biopsy, including exacerbation of visual loss, CSF leaks, and seeding of infection into the CNS can be avoided. And these are the articles I have came across, and thank you.
Nice presentation. Very well documented, a rare manifestation of a very common disease. Before we go to the questions, Dr. Pavitra Paneerselvam, is she here? Be ready there.
Both anti-tuberculous and steroids are started together simultaneously, or was there any
First
difference?
anti-tubercular medication, sir, and then steroids.
How long?
Like after 1 month.
You're a postgraduate?
Yes.
Yeah. Can you give me a differential diagnosis for cherry red spot?
cherry red spot can be in like CRVO,
Vivo.
sorry,
Okay.
central retinal artery occlusion, and diabetic retinopathy,
Okay. What causes?
tuberculoma of this optic.
Okay. What causes cherry red spot? The appearance.
There is lack of oxygen supply to the vessels.
So the appearance. What is the cherry red spot?
There is a lack of oxygen supply to the vessels, which leads to leakage of fluid, like hemorrhage, which leads to the cherry red spot.
Why is the red glow?
The central cherry red spot. The cherry red spot. Is it a hemorrhage or is it something else?
Not a hemorrhage. It was a glow.
Just I am giving a clue. How do you get a red glow on distant direct ophthalmoscope?
Macula.
Right. Anyways, nice presentation. Right.
Thank you.
Dr. Pavitra.
A very pleasant good afternoon here. I'm Dr. Pavitra. I'm doing my DNB residency from Mahatma Hospital, Trichy. I'm here to present a rare case of a late onset drug-induced choroidal detachment. These are my co-authors. Starting with the introduction, early choroidal detachment occurs very shortly after trabeculectomy and glaucoma drainage surgery if there is an overfiltration. Its occurrence rate was reported to be around 20% in trabeculectomy and 16% in glaucoma implant surgeries. Late onset choroidal detachment is a very rare complication in this clinical settings. But previously in literature, it has been reported that anti-glaucoma medication itself can cause a choroidal detachment without the prior surgery. But there has been no mention about the ripasudil causing a spontaneous choroidal detachment. Here we have a case, a 64-year-old male who came for us glaucoma review, and he has no history of any comorbidities. He was on two anti-glaucoma medication, namely the bimetoprost and ripasudil. His uncorrected visual acuity was 618 in right eye, 69 in left eye, and the best corrected visual acuity was 6 in both eyes, and the near vision was N6. Coming to the anterior segment examination, he has grade 2 cataract in both eyes, and the posterior segment shows glaucomatous optic atrophy in both the eyes. And his IOP was measuring about 16 millimeters in right eye and 19 millimeters in left eye with Goldman applanation tonometry. His visual field shows a mean deviation of minus 26.65 in right eye and 27.83 in left eye. So we arrive at a diagnosis of advanced primary open-angle glaucoma with glaucomatous optic atrophy in both eye, where left eye shows more severity when compared to right eye. So we are advised for a cataract extraction with PCIOL implantation and trabeculectomy with mitomycin C in the left eye. The surgery went uneventful, and 1 week post-op review, the patient came. He had the anterior segment finding showing a deep anterior chamber with a flat bleb and surgical iridectomy scar. And the best corrected visual acuity was 6.6, and his IOP was under control with 13 millimeters of mercury with no AGM. 2 months post-op visit, the patient came and the same anterior segment findings were there, the same visual acuity, but his IOP was increased from 13 to 18 millimeters of mercury. So in order to achieve the target IOP and considering a severe visual field defect, we restarted him on bimetoprost and ripasudil, which he was all using previously before surgery. And we asked the patient to review after 2 weeks, but the patient lost a follow-up. 2 months later, he came with a complaint of blurred vision in his left eyes for the past 2 weeks. So the anterior segment shows a shallow anterior chamber, and his visual acuity has been decreased from 6 to 612, and his IOP has dropped to 5 millimeters of mercury. His posterior segment, the fundus examination shows a choroidal detachment, and we did a B scan, which shows a 360-degree choroidal detachment. It's a serous choroidal detachment. So we advised him to stop the ripasudil eye drops in left eye, and we started him on topical steroids hourly and systemic steroids at the rate of 1 milligram per kg body weight, and we tapered the dose over 6 weeks. Later, after 1 week of this treatment, we reviewed the patient, and the anterior chamber became deep and with a flat bleb. His vision improved from 612 to 69, and his IOP was under control. The fundus and the B scan showed resolving choroidal detachment. Furthermore, the patient didn't experience any recurrence after the choroidal detachment, and this is the picture showing the fundus and the B scan before and the after treatment. So in our case, though it can be argued that the choroidal detachment here is caused by ripocida alone, it did not precipitate the attack in the first place, but it could be an idiosyncratic reaction with the other agents like the bimetoprolol, which is already using. The fact is that the condition started showing a reversal of its symptoms after stopping the ripocidal eye drops. So this indicates a causal relationship between the two, and moreover the other medication, the bimetoprolol, which he was using for a longer time. So only the ripocidal eye drop was recently added. So the best method to prove this causality is to re-challenge the patient, but re-challenging may not be ethical, and sometimes it failed to produce the event. So in conclusion, this is a late onset choroidal detachment by topical ripocidal when it was started on the setting of hypotony. So it resolved on withdrawing the ripocidal eye drops and initiating on the topical and systemic steroid treatment. So these are my references, sir.
So if you withdraw even the bimetoprost, do you think that it would have resolved on its own?
Yes,
instead
sir,
of
but
ripocidal?
we thought of first trying out with the ripocidal. So with ripocidal, if it is not settling, we thought of withdrawing both ripocidal and bimetoprolol. So we tried first with the ripocidal. With that itself, the patient started showing symptoms. The choroidal detachment was resolving, sir.
How many months is it post trabeculectomy surgery?
It was 2 months post surgery, sir.
2 months.
Yes, sir.
Okay. So is it mentioned in the literature that following a trabeculectomy,
Yes,
the
sir.
choroidal detachment can happen either in the immediate post-op or
Yes, sir. It
late
is there in
post-op?
the literature, but immediate post-op is frequently seen, but late post-op it is
It's
very
rare,
rarely.
but it is still seen,
Yes,
right?
sir. Yes.
So, like, is it a possibility that the patient has rubbed his eyes, or there is a mechanical injury to the bleb and there is an overfiltration for a few minutes, which has induced? I'm playing a devil's advocate because before accusing a drug
Yes.
of causing this,
Yes, sir.
we need to ask.
Yes, sir. We inquired with the patient, but patient didn't show.
Yeah,
he
usually
didn't
they
give
won't
his,
know, but in the sleep they might have done. That is one thing. So yeah, it's an interesting case because there has been talk about this ripocidal causing certain issues.
Yes,
But
sir.
before actually pointing a finger at a new drug,
Yes, sir.
it would have been good if you have just stopped ripocidal, not started steroids.
Okay, okay, sir.
Because now even if you have continued the drug and started steroids, it would have been the steroids can take care of the CDs very well, especially post-trap.
Okay, okay, sir.
Those things. Maybe if you had tried that, still you could not have blamed the drug, but at least it would have been, somewhere
Oh,
near that. Okay. Yeah. Thank you.
thank you, sir.
Everybody, myself Dr. Alokit Sharma, I'm second year resident presenting a paper on retinopathy in blood dyscrasias and its impact on visual impairment and quality of life. The term blood dyscrasias pertains to abnormalities in the cellular components of the circulatory fluid encompassing RBCs, WBCs and platelets. Blood dyscrasias pose significant challenges to health and manifest a wide spectrum of ocular, particularly retinal effects. The vulnerability of retina arises from the delicate and intricate nature of its structures, resulting in a diverse array of ophthalmic presentations. Anemia is one of the most prevalent abnormalities, followed by leukemia, thrombocytopenia, and more. Hemodynamic shifts and direct infiltration by leukemic cells, among other factors, render the retinal circulation susceptible to hypoxic damage. Fundus examination serves as a unique window, affording an unparalleled direct view through which vascular alterations associated with blood dyscrasias can be observed in vivo. There exists a dearth of literature addressing the impact of blood dyscrasias on quality of life related to vision. This cross-sectional study emphasizes on retinopathy and its influence on the quality of life associated with vision in individuals with blood dyscrasias. The aim of my study is to study retinopathy and its impact on vision-related quality of life in people with blood disorders. So this is a cross-sectional observational study carried out for a duration of 1 year and 9 months, and consecutive sampling technique was used for participant selection. Patients of all age groups and both genders were included, and patients having diabetes, hypertension, AIDS, renal failure, dense cataractus changes, and other media opacities which preclude posterior segment examination were excluded from the study. A total of 200 eligible cases were selected. The medical history and records with prior hematological investigations were taken, and detailed ocular examination was carried out. Fundus diagrams and photographs were captured. The assessment of vision-related quality of life was carried out using the National Eye Institute Vision Visual Functional Questionnaire 25, validated interview version of the NEI VFQ 25 were administered to participants during in-person interviews at the hospital. This questionnaire included inquiries related to general health, vision difficulties in performing activities, and responses to vision-related challenges. In our study, iron deficiency anemia was found in 52% of the total patients, which are followed by AML, ALL, thrombocytopenia, CML, and CLL, and others. In our study, most common retinal finding was venous dilatation and tortuosity, which was followed by intraretinal hemorrhage, white-centered hemorrhages, soft exudates, subhyaloid hemorrhages, arterial attenuation, and others. In our study, venous tortuosity and dilation was the most common retinal finding in iron deficiency anemia, which was followed by intraretinal hemorrhages, soft exudates, white-centered hemorrhages, and arterial attenuation. In B12, vitamin B12 deficiency, the most common retinal finding was intraretinal hemorrhages, which was followed by white-centered hemorrhage, arterial attenuation, and venous dilatation. In sickle cell anemia, the most common retinal finding was intraretinal hemorrhage. The prevalence of retinopathy in leukemia in AML and ALL, the most common finding was venous tortuosity and dilatation, which was followed by white-centered hemorrhages, which was followed by intraretinal hemorrhages and vitreous hemorrhage. In thrombocytopenia, the most common retinal finding was venous tortuosity and dilatation. In other blood dyscrasias, the venous tortuosity and dilation was found to be the most common retinal finding. The current investigation unveiled a noteworthy nexus linking retinopathy with the realm of blood dyscrasias and the subscales of NEI, VFQ encompassing general vision, near activities, distance activities, mental health, color vision, peripheral vision, role difficulties, and social functioning. Nevertheless, within the domains of ocular pain, dependency, and driving, our findings failed to disclose any statistically consequential associations. Anemia often presented with characteristic retinal manifestations including hemorrhages, rod spots, exudates, cotton wool spots, retinal edema, and venous tortuosity. Anemic retinopathy was more likely to occur in severe anemia. However, leukemic retinopathy encompassed retinal findings such as pre-retinal and intraretinal hemorrhages, rod spots, cotton wool spots, exudates, retinal venous tortuosity, perivascular sheathing, and neovascularization. In this study, 47.6% of leukemia patients exhibited leukemic retinopathy. Retinopathy was seen in 56.25% of patients with thrombocytopenia, particularly in patients with in which anemia was co-associated. Vision-related quality of life was assessed using composite scores, with general vision most significantly impacted, followed by other aspects such as distance activities and color vision, etc. To conclude, the realm of blood dyscrasias present a significant global health challenge, often leading to various vision-threatening complications. Our study underscores the critical importance of regular ophthalmic screening and fundus examinations for individuals with blood dyscrasias, both as an initial assessment and as an ongoing monitoring strategy to avoid detrimental impacts on their vision-related quality of life. These are my references. Thank you.
Yeah. A nice presentation, Dr. Alokit. A lot of useful data, excellent data. Couple of things which you can better yourself. The slide was packed with too many lines. Okay, it was little too crowded, and you did not define your inclusion criteria very well. You have not defined the blood dyscrasia, just a one term. So what is your inclusion criteria in terms of the disease, diagnosis one, second the blood test. So then you will know like what are the sampling criteria. The sample size which you are taking comes from this particular sampling. Any patient who has a blood, the diagnosis proven by this particular test with this is the value, cutoff value, this will be included. So if you make these changes and little more subgroup analysis, it will be an excellent data to publish.
Thank you.
You mentioned retinal venous tortuosity is the most common feature
Yes, sir.
in all dyscrasias. Have
Yes,
you
sir,
further studied why it is so?
Sir, because of most of these blood dyscrasias cause retinal hypoxic changes mostly, and because of that the first manifestation to occur in the retina is vascular dilatation.
That's why I mentioned if you do a subgroup analysis, there is hyperviscosity is one thing which can happen. There's an anemia, another thing. So there are two things which are playing here. One is ischemia, another one is hyperviscosity. There's sluggish blood flow. So if you do a subgroup analysis, add to that an OCT or an FA, other ocular diagnostics, this will be an excellent data to publish.
So, thanks.
Dr. Shifa?
Financial disclosure. Multiple myeloma is a hematological malignancy which is characterized by the accumulation of clonal and malignant plasma cells in the bone marrow. It produces abnormal immunoglobulins such as M protein and paraprotein. Therefore, it is known as paraproteinemia. It is detected in the blood or in the urine of multiple myeloma patients. It is a treatable but not curable disease. Clinical features are bone pain, fatigue, weakness, frequent infections, anemia, renal failure, hypercalcemia. Ocular findings are corneal deposits, scleritis, pars plana cyst, choroidal infiltrates, retinal capillary microaneurysm, hyperviscosity, retinopathy, maculopathy, and CRVO. So I present a case of 62-year-old diabetic female which came with a decrease of vision in both eyes since 1 year. She was diagnosed elsewhere as non-proliferative diabetic retinopathy with macular edema in both eyes, and she was treated with intravitreal anti-VEGF injection in both eyes and triamcinolone in the right eye. Followed by there was no improvement in treatment, so she came for a second opinion. On ocular examination, her best corrected vision was 6/24 N18 in the right eye and 4/60 N36 in the left eye. Her anterior segment findings were normal except there was early cataract changes. On fundus examination, there was a large neurosensory retinal detachment with yellow subretinal fluid exudates. On OCT, there was a huge neurosensory detachment in outer retinoschisis. On FFA, we reviewed her old FFA. There was no perifoveal leak corresponding to the degree of neurosensory detachment describing as silent macula. So angiographically silent macula rules out that the disruption of the blood-retinal barrier is the primary mechanism for the subretinal fluid accumulation, thus ruling out to be diabetic macular edema. It prompted to look for other systemic conditions like compromised renal function. So we did a renal function test and it came to be out normal. So refractory nature of the macular edema, normal renal function test, and silent macula on the FFA prompted us to evaluate for immunoglobulopathy. We investigated electrophoresis which showed M proteins. We did a whole body PET scan and bone marrow aspiration which suggested of a multiple myeloma. Then we started a medical oncology consultation and chemotherapy was started. On follow-up, there was no improvement in vision, but fundus show resolved neurosensory detachment and signs of NPDR with RPE changes. On OCT finding, on both eyes, there was complete resolution of the neurosensory retinal detachment and subfoveal RPE changes was present in both the eyes. On FFA, there was a window defect in the macular area and NPDR changes were seen. So our final diagnosis was both eye paraproteinemia maculopathy secondary to multiple myeloma with early cataract and mild NPDR. Discussion. Paraproteinemia maculopathy is a rare ocular manifestation of monoclonal gammopathy like multiple myeloma. There is an increase in the level of IgM which enters into the subretinal space causing local ischemia and increase in the osmotic gradient causing accumulation of fluid in the subretinal and intraretinal spaces causing neurosensory detachment, thus showing in FFA as angiographically silent macula and excluding the blood breakdown of blood retinal barrier. So the silent macula is a crucial feature distinguishing from the macular edema due to breakdown of blood retinal barrier seen in the diabetic macular edema, age-related macular degeneration, uveitis, and retinal vein occlusion. We also need to rule out other ocular and systemic conditions such as retinal dystrophies, optic nerve head pits, myopic tractional maculopathy, toxic effects of drugs such as taxanes and Cohen syndrome. This can be excluded by history and examination. So my take-home message is, though rare, paraproteinemia should be suspected in middle-aged to elderly patient with macular edema. In case of silent macula on FFA, early recognition and referral to an oncologist leads to timely diagnosis and appropriate management, save life and save sight. Thank you.
postgraduate?
Yes, sir, I'm second year.
Okay. How do you classify macular edema on a fluorescent angiogram? Diabetic macular edema.
Sir, there's on FFA, sir.
Yes.
There's leakage of the microorganism leakage, hyperfluorescence.
How do you classify?
Classify, sir.
Is there a classification, FA-based classification of diabetic macular edema, clinically, OCT based and angiogram based?
OCT based, we have a classification.
Angiogram based, is there?
Angiography.
I've heard of ETDRS study.
Yes, sir. Early treatment diabetic.
So it does give FA classification. Are you aware of that? Yes or no? So you're presenting a case on this, so you should be aware of it, right?
Sir.
So basically, silent macula, by saying silent macula, what we mean is any diabetic patient, when you come across macular edema, and you're not able to find the cause for it. So what is the cause for diabetic macular edema? Either a leaking microorganism or a leaking capillary, right? On an FA, you're neither seeing a leaking microorganism nor a capillary.
Yes.
That means the source of leakage is from
somewhere else.
now
Transudation.
diabetes is not the cause.
The
So
cause
this
of
is
the
how you end up, though the patient, the diagnosis leads towards the diabetic macular edema.
Yes.
These are the red flags,
Red flags.
where you have to see that, okay, this is not because of diabetes and because of something else.
Something else.
And then you go on investigate.
Yes, sir.
Okay, right. Thanks.
Thank you, sir.
Dr. Jessica, she'll be presenting on atypical visual field defects in atypical retinitis pigmentosa. Do we have Dr. Sumit here? Dr. Sumit Randir Singh.
Good afternoon, respected judges and all the dignitaries present here in the room. My name is Dr. Jessica Basumatari, and my paper is on atypical visual fields in atypical retinitis pigmentosa. So it is a case series of 3 cases. I don't have any financial or conflict of interest. To highlight the challenges, the purpose was to highlight the challenges in diagnosing atypical cases of retinitis pigmentosa and the importance of 120-degree visual field analysis in such cases. Coming to introduction, retinitis pigmentosa is a hereditary retinal dystrophy that was first described in 1853. It is characterized by progressive degeneration of rod photoreceptors, though eventually cones are also involved, leading to severe visual impairment. The classical features include a triad of bony spicules-like pigmentation in the mid-peripheral retina, waxy disc pallor, and arteriolar attenuation. Atypical RP may not present with these typical features, making its diagnosis a challenge. Sectoral RP, RP sign pigmento, and retinitis punctata albicans are some of the atypical phenotypes of RP. Visual field loss in RP begins as patchy loss of mid-peripheral and peripheral field, followed by ring scotoma, tunnel vision, and involvement of the central vision at the end stage. Case 1. He was a 52-year-old male coming with the chief complaints of blurring of vision in right eye since 3 months. He had a history of cataract surgery in right eye 3 months back, and on examination, the BCV in the right eye was 618, in the left eye it was 69. PCIOL in the bag was in the right eye, and left eye had NS grade 2 cataract. So this was the 30-2 Humphrey field report. So what we see here is that there is scotoma which appears to be respecting the vertical midline. In RP, the scotomas are usually paracentral, and then ultimately a tunnel vision is remaining in the end stage of the disease. So here in the right eye, it seems like it is respecting the vertical meridian like a binasal field defect. This is the 120-degree supra threshold test full field on the right-hand side. So on ERG, we see that the photopic and scotopic responses are grossly reduced. On OCT, there is a cystoid macular edema in the right eye. FFA shows a pitaloid appearance. This patient was then treated with topical carbonic anhydrase inhibitor and NSAIDs. After 6 months, the edema resolved. However, at 1 year follow-up, there was a recurrence of the CME, and the final visual acuity in the right eye was 6/12. The key points here to discuss is whether the CME was due to retinitis pigmentosa or whether it was because of pseudophakic CME. Because of the duration of presentation, the patient presented to us at 3 months, which is the classic duration of presentation in Irvin-Gass syndrome. So in RP, CME can result in drastic reduction in visual acuity. It is seen in 10 to 50% of patients. The pathogenesis of these two conditions are varied. However, the treatment line is similar. Now, what is binasal field defect, even if there is such a thing? Now, we know that bitemporal field defect is due to optic chiasmal compression, but what about binasal field defect? There have been some studies reporting that there can be complete binasal hemianopia, like the one that I have quoted, and according to them, the pathogenesis is because of a defect in the normal sorting of the ganglion cells that decussate at the optic chiasma. Other causes, ocular causes, could be ischemic optic neuropathy, optic nerve head-Rusin, glaucoma, retinitis, and pigmentosa, like we see in this case. However, mostly binasal field defect is artifactual, and it is due to a defect in the testing procedure. Case number 2, 44-year-old male with nil systemic features. Chief complaints is difficulty in ear work since 1 year. The fundus shows scattered bony spicules in the periphery. And in the left eye, what we see is that superiotemporal dyspallor can be noticed. BCVA is 6.6 both eyes and N6 with plus 1.5 diopter spherical correction. Color vision is defective in the left eye, pupil is normal both eyes, and the lens is clear. So what we see here is that inferiorly, in the 30-2, there is an inferior altitudinal field defect. So can this be an AION, that is non-arteritic anterior ischemic optic neuropathy? The patient was also found to be taking tablets sildenafil, which is a phosphodiesterase 5 enzyme inhibitor, which is the risk factor for AION. This is a 120-degree visual field here. In the 30-2, it seems like only the inferior altitudinal field defect is present. However, when we see this, we can also appreciate the scotoma in the mid-peripheral, beyond the 30-degree in the superior arcuate region. So a depressed ERG response in both photopic and scotopic conditions. Sildenafil can result in AION, can also aggravate retinitis pigmentosa. It affects the phototransduction. Case number 3, 70-year-old female. Right eye 636, left eye 660. It seems like there is retinitis punctata albicans, sharp foveal reflex. However, when we look at the visual field, there is center involving scotoma. Conclusion, all 3 cases, the classical signs were not present. On top of that, confusing visual field defects and classical signs provided a diagnostic challenge. In the absence of typical signs, the diagnosis can be challenging, especially in low resource economy like ours, where genetic testing may not be easily available or feasible. So a full field suprathreshold visual field analysis covering 120 degrees superior over the standard 30-2 and hence should be part of the routine testing in suspected RP cases. These are my references. Thank you.
Nice, interesting cases. Dr. Jessica, you are a resident?
I'm a fellow in medical retina.
Fellow in medical retina, okay. How do you diagnose retinitis pigmentosa? What is the criteria? If you want to diagnose, what is the diagnostic necessity?
Diagnostic necessity, if you talk about symptoms, the patient will present with night blindness. If you talk about clinical features, then the classical triad, there can be genetic testing, which is...
Is the classical triad must? So you mean
not
to say...
necessarily.
You mean to say a patient who has a normal fundus, and if he comes to you and says that my father or mother had a retinitis pigmentosa, please examine me, and patient is say at 11 or 12-year-old, you're going to say that the patient, you know you don't have a retinitis pigmentosa, you need not be worried?
Sir, we have to also do ERG testing, and we should take down the history of the patient. We have to have a pedigree charting, find out the kind of genetic inheritance pattern.
What is the diagnostic criteria?
ERG.
Is it ERG? So the diagnostic criteria for RP, what we read classical triad is in this end of spectrum. When the patient comes to you in the early spectrum, demonstrable dark adaptation, delay in dark adaptation is the first sign or a symptom which a patient can come up with. Everything else will be normal. Disc, vessels, no bony spicules, everything will be normal. So you have to demonstrate the delay in the dark adaptation. Okay, so that is the first earliest sign that can be. Of course, the definitive test will be the ERG, and then comes your clinical pictures. That is the disease process. Slowly, when there are different varieties of a gene.
Yes, sir.
In some varieties, there can be a full-blown picture at the age of 10, by the beginning of the second decade. But there are certain genes where you may not see the signs till the 4th or 5th decade. So RP has a varied appearances. Retinitis pigmentosa itself is a misnomer. Retinitis, it's not an inflammation. Essentially, it's a rod cone dystrophy.
Yes, sir.
Okay?
Yes.
So the classical triad is for an undergraduate to remember as waxy pallor of the disc, the narrowing of the vessels and bony
Bony
spicules.
spicules.
But
Right,
for a
sir.
fellow like you should have done a good research
Okay, sir.
on what is the diagnostic criteria for a rod cone dystrophy
Okay.
and how do we go about treating it.
Okay.
Anyways, very nice collection of cases.
Thank you so much, sir.
Like this if the present. So the answer will be bony spicule is just a sign. It is not a diagnostic criteria or the diagnostic thing for an retinitis pigmentosa, the rod cone dystrophy. Many times a spontaneously settled RD can bring up a pigment clumps like this. Post-inflammatory lesions where you have an exudative detachment, and when that dissolves, you can have the pigmentation like this. So multifocal choroiditis, a sectoral multifocal choroiditis can have scarring like this. So whenever you see scars like this, do not jump on the conclusion of retinitis pigmentosa. In fact, there is nothing like atypical retinitis pigmentosa. It's either a varied presentation of a rod cone dystrophy or it is not retinitis pigmentosa at all. So that was the term which was commonly used before. But now with the advent of many more diagnostic tests and clinical genetic evaluation and ERG, EOG available, the diagnosis is based on all these investigations and correlated with the patient's symptoms and the signs what you see. I'll hand it over to I think we are on time, 5 minutes early. We'll hand it over to the next session, which is, will be taken. Pediatric ophthalmology.